We are now answering another question. Can device interrogation programming change your treatment strategy for your patient and the interaction between programming and your clinical decisions for each of your patients? The concept: today's pacemakers and defibrillators have improved diagnostic tools to detect and treat cardiac arrhythmias, as well as generating data about clinical status of our patients. So reviewing this data can be a cornerstone for an updated, personalized management plan for the patient. And if we plot this process of interrogation against the latest WHO definition for a biomarker, stating that any substance or process that can be measured in the body influence and predict the incidence of outcome or disease, you might agree with me that this process of interrogation can be considered as a biomarker leading to our clinical decisions. So CID programming usually has these components. We look at the alerts generated by the system, the battery longevity, the performance of the parameters of the device, the clinical events and the clinical status of the patient, as well as our parameters. And from each of these sections, we can derive data that can help us taking clinical decisions and putting strategies for our patients. The examples are many. I will go through some, like the ERI Alert, the atrial high rate episodes by the CID, which might be deflecting silent atrial fibrillation, which is crucial to prevent the potential embolic complication this era are related to. They are detected in like 10 to 15% of our patients. They are significantly associated with overt atrial fibrillation and ischemic stroke. However, sometimes they are misleading alerts, and we have to look at the generated and integrated EGM to confirm the diagnosis, like in this EGM having this disturbed activity, high rate activity in the atrium, denoting which might be atrial fibrillation. We have to exclude that it's not a misleading over-sensing, under-sensing, far field, and other criteria that can mislead the diagnosis of atrial fibrillation. Moreover, and to complicate the clinical decision based on this interrogation, that stroke in ERI alerts might be attached with lower stroke risk than patient with atrial fibrillation. More often, strokes can happen without having ERI alerts for more than 30 days before the event. At present, pacemakers and implanted device should be interrogated for the presence of ERI, and these patients should undergo further assessment of stroke risk factors and overt atrial fibrillation, including ECG monitoring. And this is the algorithm from the latest ESC guidelines for the management of atrial fibrillation. For any patient who have ERI more than 5 to 6 minutes at a rate above 180, you should risk stratify him. Is he at high risk, high CHA2DS2-VASc score, high risk for stroke? If not, you don't need to do further assessment. If yes, you have still to work to document this through an ECG, Holter, or even a leadless ECG if it's available in your device. And if the CHA2DS2-VASc score, it's a class 1 evidence to start your oral anticoagulant, and as we see here in the latest guidelines. The same goes for atrial flutter with cardioversion or overdrive pacing and WAC prescription. The ICG therapy alerts and how they can affect our clinical decisions, if they are appropriate or inappropriate. Starting with appropriate, your treatment strategy will be based on searching for the reversible causes, electrolyte disturbance, thyroid disease, and even the potential pro-arrhythmic effect of our anti-arrhythmic drugs, drug toxicity, optimal device programming, drug therapy, VT catheter ablation, and for refractory VT going even into sympathetic denervation as a clinical decision. It could be a simple strategy of increasing the number of intervals to detect to deliver the shock, which has been proven a safe and effective way, especially in non-ischemic primary prevention patients receiving ICDs. It will decrease the unnecessary shocks and the charging of the capacitors aborted. or using and optimizing and up-titrating your drug therapy and strategy. Beta blockers are the cornerstone. Class 3 antiarrhythmics, the sotalol and the amiodarone in their different combination, especially the combination of amiodarone beta blockers, amiodarone mixilitine, and we have a cohort of patients that have been saved from VT storms and frequent VTs with this combination of mixilitine and amiodarone. Up to having the decision to go for catheter ablation, which is used as a next step for secondary VT ablation when the AED are insufficient or failing, and have been successfully used as a bailout procedure in patients with incessant VTs and VT storms. Up to going to a neuroaxial blocking through surgical or temporary thoracic epidural anesthesia, highly effective, especially when used as a bridge for a more definitive treatment like catheter ablation. If your patient have these types of alerts of ICD therapy and having signs of heart failure or signs of ischemia, you might go for revascularization guided by viability studies. You might go to upgrade his ICD into a CRTD, because we have a wealth of data now that biventricular pacing decreases the incidence of ventricular arrhythmia, as seen in the MADIT CRT study, with 55% reduction in VT risk. Moreover, biventricular ICD pacing is more effective in terminating slow and fast VT, and hence decreasing the need for ICD shocks in these patients. If they are inappropriate shocks, the most common is SVTs, and you will go with the clinical decision to go with the conventional treatment of SVT, either pharmacological or ablation. Don't forget to open and use your algorithms needed to discriminate, especially the wavelets, the stability, the onset. Also placing, sometimes the solution is placing an atrial lead to improve the discrimination and upgrade your ICD into a dual chamber ICD. Another type of alert that can affect your decisions, the optivol threshold alert. Optivol trend tracks intrathoracic impedance changes over time. And we know that the more the lung become congested, intrathoracic impedance tend to decrease, and the inverse is true. The more it's dry, the impedance increases again. And this is how we read. We have two graphs, one that shows the trend for the impedance, the intrathoracic impedance, and once impedance decreases means the volume and the fluid is increasing in the lung, and once it passes through the threshold set by the CIED, an alert is generated, and you can take action upon this alert. This has been thoroughly studied in many studies. Impedance monitoring will show your patient's symptoms as seen in the mid-HAFT trial. It will predict need for heart failure hospitalization. It will be more effective than monitoring weight and body weight alone. It can predict readmission for heart failure. It can even predict risk for arrhythmia and risk for long-term mortality for patients with heart failure. And this is the way we read it using both graphs, and it's maybe more beneficial to combine with other graphs showing the clinical status of the patient, namely the physical activity of the patient during this period, the heart rate, and the arrhythmia load of the patient during to improve the interpretation. This is an example of how you can use this alert. This is a patient that his optivol has exceeded the threshold. The alert has been generated. The patient has been called to have his education, diet, and mitigation sent to his cardiologist, the cardiologist who have up-titrated his diuretics, and hence the curve is again normalized, and you have prevented an avoidable hospitalization. Another alert, the percentage of biventricular pacing. We know in CRT we want the lowest or the slowest, which means the latest site of activation, and we want the highest percentage of biventricular pacing, a threshold of more than 98%. So if you have this alert of biventricular pacing below this threshold, you should optimize. You have to take the strategy, the medical and the clinical decision to optimize the control of PVCs, beta blockers, AEDs, optimize fluid status, optimize programming, maybe by optimizing AV delay, sync AV, adaptive CRTs that can be, if are available, can be useful in such cases. Another alert that can guide our decisions, the battery ERI alert. And actually, according to the latest ESC guidelines for management of heart failure, at that time, you should not automatically replace an ICD battery when it comes to ERE. You have to re-evaluate again your patient because your treatment goals may have changed and the risk for fatal arrhythmia may become lower, or even the risk of non-arrhythmic death have been higher. If your patient has a QRS wider than 130, maybe you can consider, if it's symptomatic, to put a CRTD rather than an ICD. If the patient is too ill to benefit, like in an EHA4 in a patient not candidate for CRT, maybe you will not put an ICD because the life expectancy is poor. Lastly, I will put this example of interaction between CID programming and your treatment strategy. 60 years old, Mr. MA1, 60 years old, ischemic cardiomyopathy, ejection fraction 20%. His history or story started in 2010. Acute myocardial infarction, ejection fraction dropped to 20%. In 2012, he had multiple VTs. He has been resuscitated and was implanted with a CRTD. He went fine till 2016, when he started to decompensate again. First day hospitalization, signs of congestion, signs of hypoperfusion, despite being well treated by medications. ECG showings, always biventricular pacing. He should be doing better. After 11 days of IV diuretics, IV inotropes and vasopressors, patient improved and was discharged. Yet 10 days later, he was re-hospitalized with decompensation. Again, we had this picture in mind that the more hospitalization, the more aggregated events, the higher the mortality. After 14 days, he had a negative balance of 36 liters. Despite that, it was very difficult to wean him from IV supports. We can say intermax maybe 4, maybe 5. Patient was discharged, and less than 30 days again, he was re-hospitalized. And we were thinking he was getting into this loop of admission, re-hospitalization, dependency, and refractory heart failure. We might be in time to change our treatment strategy, to go for palliative treatment, to start family counseling, until that day when Professor Mervet have suggested and supervised echo-guided CRT optimization. And we did it optimizing the AV delay, the VV delay, through the transmitral Doppler flow, through the LVOT VTI. The ECG didn't change much after the optimization, as you can see pre and post, but that was the last hospitalization for this patient since 2016 till now. After this optimization and this interaction, the patient is conducting a nearly normal life, 3 years follow-up, last hospitalization is the last stated. So yes, CID programming changed our strategy for this patient and many others. Thank you very much.